In trauma surgery, the golden hour isn't just a catchy phrase. It is a literal physiological countdown. The absolute second a patient suffers a critical injury, a clock starts ticking toward irreversible shock and systemic failure. So we're going to strip away the classroom theory today and test your raw surgical instincts with some rapid-fire, high-stakes clinical case reviews. Let's get our first patient to the trauma bay.
Imagine this. A 28-year-old male rolls through the doors with a gunshot wound to the abdomen. He is crashing, and he's crashing fast. Profound shock. His systolic blood pressure is hanging by a thread at 60 millimeters of mercury. You perform an emergent laparotomy, and boom, you immediately encounter a massive retroperitoneal hematoma surrounding the infrarenal abdominal aorta and the vena cava. The bleeding is catastrophic. You literally have seconds. So looking at these four options, what's the most appropriate surgical maneuver to expose those vital vessels?
Okay, let's dive into this. The correct maneuver here is B. You absolutely need to execute a right-sided medial visceral rotation, which we know as the Kittel-Brosh maneuver. In a desperate scenario like this, mobilizing the right colon, the hepatic flexure, and the small bowel mesentery all the way up to the ligament of Treitz, that is the only way to reflect those abdominal viscera to the upper left quadrant. It gives you wide-open, optimal exposure of the entire infrarenal abdominal aorta, the IVC, and the iliac vessels so you can actually gain vascular control. Now, if you chose the Maddox maneuver, the left-sided rotation, you'd be looking at the Zone 1 supercell level aorta. And frankly, that is just the wrong anatomical zip code for this specific injury.
Moving right along to our next diagnostic puzzle. You've got a blunt force trauma patient, say a steering wheel right to the sternum. How do you definitively rule out a blunt cardiac injury, or BCI? Does an elevated troponin I alone mandate an ICU admission? Are nuclear medicine studies your first line, or is it a combination of a normal ECG and a normal troponin? What do you think?
The absolute crucial number here is 100%. According to the Eastern Association for the Surgery of Trauma guidelines, if you have a completely normal admission screening 12-lead ECG combined with a normal baseline serum troponin I level, your negative predictive value approaches 100%. You can effectively and safely rule out a clinically significant blunt cardiac injury. Listen, isolated troponin bumps without any ECG changes or hemodynamic instability, they do not automatically buy your patient a ticket to the intensive care unit.
Let's jump into a critical care crisis in the ICU. We have a 45-year-old male intubated on day 4 after an emergency laparotomy for a ruptured appendix. He's got a temporary open abdomen closure. Suddenly, the alarms start blaring. His tidal volumes drop. Peak airway pressures spike from 22 all the way up to 38 centimeters of water. His urine output has basically dried up to less than 10 mils an hour, and a transducer shows his bladder pressure is soaring at 28 millimeters of mercury. What is your immediate, life-saving action here?
The answer is C. You must immediately open that temporary abdominal closure right at the bedside. This patient is crashing hard from abdominal compartment syndrome, or ACS. Now you might be thinking to yourself, wait, his abdomen is already open. Yes, it is. But even with an open abdomen, if that temporary closure is too tight, or if massive retroperitoneal and visceral edema expands beyond what the dressing can handle, a sustained intra-abdominal pressure above 20 millimeters of mercury is going to crush those organs. That pressure physically pushes up on the diaphragm, which causes the respiratory crash, and it compresses the renal veins, causing the oliguria. A bedside decompressive reopening is quite literally the only way to instantly restore compliance and save his life.
Shifting our focus to the retroperitoneum now, you're exploring a penetrating injury to the left flank. As you navigate the cavity, you spot a stable, non-expanding Zone 2 retroperitoneal hematoma. There's no gross hematuria, and importantly, your preoperative CT scan already showed symmetric, perfectly healthy renal perfusion. So, here's the dilemma. Do you explore it, do you aspirate it, mobilize the colon, or do you just leave it alone?
The correct move is option C. You observe and leave that hematoma entirely undisturbed. Remember, Zone 2 encompasses the perinephric space. In the case of a blunt or penetrating mechanism where the renal injury was already preoperatively staged as stable, meaning no major collecting system disruption, and the hematoma itself isn't actively expanding, opening that space is a complete trap. Exploring a stable perinephric hematoma often releases the body's natural tamponade effect. That leads to massive hemorrhage, which frequently results in an entirely unnecessary nephrectomy. Save the kidney, guys. Just leave it alone.
Let's jump straight up to the thoracic outlet. A 30-year-old male presents with a penetrating injury to Zone I of the neck, right down at the base.
He's got a pulsatile hematoma and a palpable thrill, which are obvious, clear-cut signs of vascular trauma. However, he's actually remarkably hemodynamically stable for the moment. So before you rush him to the OR, what's the most appropriate diagnostic test to delineate his vascular anatomy? You're going to want option C, a computed tomography angiogram, or a CTA of the neck. Zone 1 injuries are notoriously tricky because the anatomy is essentially hiding behind the clavicle and the sternum. They are incredibly difficult to expose rapidly if you just go in blind. Because our patient here is stable, getting that CTA is absolutely critical. It shows you exactly where the vascular defect is, which lets you plan ahead. You'll know for sure whether you need to crack the chest with a median sternotomy or if a supraclavicular incision is going to do the trick.
All right, let's look at a classic trauma physiology question, but one that honestly gets misunderstood a lot. We all know a tension pneumothorax is a massive, lethal emergency. But what is the exact primary physiological mechanism that actually kills the patient if it goes unmanaged? Is it just that the lung collapses and they run out of oxygen? Let's take a deep dive into the collapsing respiratory system.
And this brilliantly illustrates the real difference between respiratory failure and obstructive shock. The correct answer is C. Sure, hypoxia happens, but the patient usually dies from cardiovascular collapse way before that. Here's the step-by-step. As intrathoracic pressure progressively rises, it forces a massive mediastinal shift. That physical shifting compresses the low-pressure superior and inferior vena cava and literally kinks the cavo-atrial junction. Blood simply can no longer return to the right side of the heart. Preload drops to absolute zero, cardiac output vanishes, and the patient codes. So you aren't just reinflating a lung when you decompress them, you are unkinking the plumbing to their heart.
Pivoting seamlessly to neurotrauma now, a 19-year-old male takes a massive blow in a motorcycle collision, giving him a severe closed head injury. His Glasgow Coma scale is a grim 6. Currently, his blood pressure is sitting at 135/80. As the clinician managing his acute post-injury phase, how does systemic blood pressure dictate his brain's survival? What is your primary objective here?
The answer is B. You have to defend his mean arterial pressure, his MAP, at literally all costs. In severe traumatic brain injury, the initial structural impact is already done. Your entire job now is preventing secondary brain injury. Cerebral perfusion pressure is calculated as MAP minus intracranial pressure. If the brain starts swelling, the ICP goes up. If you let the MAP drop at the same time, blood simply cannot push its way into the injured brain tissue. And here's a totally sobering fact for you. Even a single isolated episode of systemic hypotension, where the systolics drops below 90, is strongly associated with a doubling of mortality. You have to keep that pressure up. It is a tightrope of trauma critical care. Picture this classic damage control scenario. You're deep into a laparotomy for multiple intra-abdominal gunshot wounds. You've worked fast, clamped the bleeders, achieved hemostasis, and completely controlled the spillage. But the patient's physiology is failing on the table. They're hypothermic and severely coagulopathic. That lethal triad is setting in fast. You need to get them to the ICU right now. Knowing when to stop operating is key. So how do you temporarily manage this open abdominal wall? The answer you're looking for is B. You're going to place a temporary negative pressure abdominal closure device, like a vacuum pack. The golden rule of damage control surgery is knowing exactly when to stop. Trying to suture the fascia under tension in a swollen, hypothermic patient, that's practically a death sentence. It directly precipitates the abdominal compartment syndrome we talked about a few minutes ago. A negative pressure dressing is amazing because it protects the exposed viscera, continuously evacuates all that protein-rich inflammatory fluid, stops the fascia from retracting too far, and keeps the whole abdomen compliant while the patient gets resuscitated in the ICU.
Let's talk about diagnostic peritoneal lavage, or DPL. Now, I want to challenge you on this one. In our modern era of lightning-fast CT scanners and bedside-fast ultrasounds, has this older diagnostic tool been completely abandoned? What's its utility today?
The correct answer is C. DPL has absolutely not been abandoned. It is still an incredibly valuable tool, specifically for hemodynamically unstable patients with blunt trauma when the ultrasound is just inconclusive. If you aspirate the fluid and microscopic analysis reveals greater than 100,000 red blood cells per microliter or greater than 500 white blood cells, or hey, if you just see gross enteric contents, that is a definitive positive test. That number, 100,000, is your absolute threshold that mandates an emergency trip straight to the operating room. All right, rapid-fire clinical presentation time to test your immediate decision-making reflexes. A 24-year-old male comes in with a stab wound to the left quadrant of his abdomen. Vitals are currently borderline stable at 110/70. But on physical exam, his abdomen is totally rigid. He has localized peritonitis and involuntary guarding. What is your most appropriate next step? Are you doing serial exams? A quick trip to the CT scanner?
So the crucial point is D, urgent exploratory laparotomy. Clinical signs will always trump the desire for perfect imaging. When a patient with penetrating abdominal trauma presents with clear, undeniable signs of peritonitis, like involuntary guarding, rigidity, or rebound tenderness, that is an absolute indication for surgery. Do not send this patient off to the CT scanner. Delaying operative intervention while a hollow viscus is actively leaking contents into the peritoneal cavity is going to significantly increase morbidity. Send them straight to the OR.
Let's look at a final, highly visceral emergency room scenario. A patient suffers a stab wound resulting in a traumatic abdominal wall evisceration. Loops of their small bowel are physically exposed and literally resting on the abdomen right there in the resuscitation bay. What is your immediate initial action? Do you try to carefully push it all back in, wrap it tightly with an elastic band, disinfect the area?
The answer is B. You immediately cover those exposed loops of bowel with clean, moist, sterile saline-soaked dressings. This prevents desiccation, which is drying out, and severe heat loss. You never, ever attempt to manually force those bowel loops back through a small fascial defect in the ER. Doing that can cause massive structural tearing and ischemia. Evisceration is basically an automatic ticket to an exploratory laparotomy. You wrap it moist, and you move. We've just sprinted through some seriously high-yield life-saving trauma data in this explainer. But consider this provocative thought as we wrap up. Sitting here calmly, these answers probably seem perfectly logical. But could you actually recall these precise physiological mechanics and make those split-second, definitive decisions when the monitors are screaming, there's blood everywhere, and a life is entirely in your hands?